55. Drive through fast on Route 55.
Mm-hmm.
That's an acronym that you use to
Yeah,
explain.
yeah, yeah. And so, and this actually kind of parallels the latest guidelines. And so the lipid guidelines actually just came out last week. And so I actually, except for the prevent risk calculator, which I have my own opinions on, I'm not a big risk calculator fan in general, but I have this acronym as far as, hey, your guidelines based approach to cardiovascular disease. And so it's drive fast on Route 55. And the 55 is the LDL cholesterol or ApoB level that you want to get under if there's been significant break-ins to your lipid neighborhood. Okay. And we see reduced cardiovascular events when we get people who have these risk factors and who have experienced serial break-ins to their lipid neighborhood when we get to those levels. And so the acronym I have, drive fast, is F is find disease. Don't rely on risk calculators, actually use things like the CAC and our other diagnostic imaging tools to find disease. And then A is for atherosclerosis. Oh, you found the atherosclerosis. Okay, there's been break-ins. What do we do about it? Well, we have tools in our lipid lowering toolbox. And the backbone of lipid lowering therapy from a medication standpoint is statins, right? But statins are not a panacea. Statins do a lot of good things, but they aren't a panacea. And the most bang for you buck you get with the statin is with your initial dose. Every subsequent doubling of the statin dose, you get maybe 6% additional LDL cholesterol lowering, and you increase side effects quite a bit. And so I'm a big fan, outside of acute coronary syndromes, to use combination therapy, knowing that you're going to not get as much out of the higher intensity doses of statins, except for side effects. And then T is toolbox. And, if the year were 2004, we would say, hey, maximize your statin and pray. I think we should always pray, but we've got tools beyond the statins that have shown in large cardiovascular outcome trials to reduce clinical events. And so we've got ezetimibe, we've got bempedoic acid, we've got PCSK9 inhibitor monoclonal antibodies. So it's a good time to be in the preventive cardiology space because we have lots of tools in our therapeutic toolbox. It's just a matter of knowing when and how to use them, and identifying our patients appropriately and finding the atherosclerosis before it becomes problematic.